Thanks, Victor. Good morning or good afternoon to all of you. Thank you for coming. It's Sunday, it's sunny, lunchtime. I do not understand why you are so numerous for a lecture on metabolic diseases. Usually it's a knee session at this time. We will see a few objectives that were asked by Victor for me to cover, and we will focus on basic pathological processes. We will try to learn the MSK manifestations of these diseases. And most of all, I will try to focus on strengths and weaknesses of each imaging modality. Because the time is limited, we will focus on metabolic, bone, and marrow diseases. And I will mention the extra-osseous changes as well as the changes that you will see in the growing skeleton. This is extremely important. We will skip major diseases. One of these is diabetes mellitus. In your everyday practice, you see all these patients with numerous MSK problems. We will not cover that disease in this session, neither with crystal deposition diseases. And most of all, inherited rare conditions will not be mentioned. So by the end of this lecture, you should remember the key imaging features that you will see if you know them in patients with bone and marrow metabolic diseases. I'd like you to be aware of this significant limitation that we will encounter, and most of all, it's important to know where you can help the clinician or the patient and where you cannot help the clinician or the patient. So we will focus, first of all, on normal metabolism. For the dummies, just a few words to remember you about bone metabolism. There are two different sorts of bone from this femur. One is the cortical bone, the other one is the trabecular bone. Well, the cortical bone is the largest amount of bone in our skeleton. It's about 80% of the bone volume that we have, but it has a very limited metabolic role to play. It's only a protective role and a biomechanical role to move. On the other hand, the trabecular or cancellous bone that you will see in the spine and in the epiphysis and metaphysis has a more important role to play because it has a high porosity. The surface of this bone, accessible for the adjacent cells, is very high, and it plays an important role. Now, to summarize the normal bone physiology, you just have to remind that there are some cells, the osteocytes, the osteoblast, and the osteoclast, and they work as a team which is composed on bone-resorbing cells and then bone-forming cells. And whatever you do in our skeleton in the adult, there is each year 5% of the skeleton which is completely modified, renewed, and this is not the same in the growing skeleton, where each year half the skeleton is replaced by another one. Now, if you look at bone mass and bone turnover, which is a very important complex concept, you must think of the skeleton at the bath, in which there is water. The level of the water is the bone mass, and obviously it depends on the equilibrium between water input or bone formation and water output or bone resorption. In addition, the diameter of the vessels are important to modify bone turnover. If there is a lot of bone resorb and a lot of bone formed, then the bone turnover is high. Well, during growth, bone mass increases and bone turnover is high. a peak bone mass is reached by the age of 25, and that peak bone mass is higher in male than in females. But after the years of 40, then total bone mass decreases, and that decrease starts earlier and goes faster in female than in male. That's it for bone metabolism. That's all what you need to know to understand the images. What about marrow metabolism? Once again, two different types of marrow. One is red, the other one is yellow. Red marrow is a mixture of these white dots, which actually is fat, adipocytes. And all these small cells which are here, which are the red, white cells forming, this is really hematopoietic tissue. So if you look at that, about 0.5% of the surface is occupied by fat, and the other 50% is occupied by the other cells. So it's a mixture of fat and non-fat cells. If you look at yellow marrow, though it's a totally different history, just adipocyte, that's it, nothing else, and a few capillaries. Now, if you look at the bone marrow on MR images, if you take that T1 weighted images, the signal intensity of the red marrow is what we call intermediate. It's neither high nor very low. And as a rule, on T1 weighted images, the signal intensity of normal marrow should be higher than that of the adjacent intervertebral disc on T1. Now, on T2, the signal intensity is variable as well, and if you inject contrast material, the enhancement between before and after contrast is relatively subtle. As a rule, although it's full with blood and vessels, the enhancement is subtle, and this is related to the relaxation time of the marrow. Now, during growth and adult life, there are significant changes that do occur. At birth, you've got red marrow everywhere in the skeleton, and then progressively it retracts over time, and in the adults, we reach probably a peak marrow mass in the years 30 or a little bit later, and that marrow mass is higher in female than in male. It's reversed to the bone mass. After the age of 30, the marrow becomes less cellular, which means that there is more fat, and that increase in fat can be either homogeneous or heterogeneous, and the bone marrow looks heterogeneous on MR. Just an example of a patient, this is at birth. The signal intensity of the bone marrow is very low on T1, and the explanation for that is that there is no fat at all. Later on, there is an increase in the amount of fat, and therefore an increase in the high signal intensity. So significant changes during growth and during adulthood. There is only minor, barely detectable change, and in a series of women and men in our department, we did the MR in 1979 and in 2007, and then there was no difference, or barely no difference, over 10 years of time. Then you will see this in your everyday practice if you do whole body MRI on T1 weighted images. The red marrow area has a intermediate signal intensity higher than the disc or the adjacent muscles, and the more distal you go, the higher becomes the signal intensity. Now, there is an important variation that I have to mention because this is a metabolic session. We call that red marrow hyperplasia. Actually, this is a normal coronal T1 weighted image in an adult woman. And this is another woman of the same age. This is what we would expect to see, high signal intensity, because it's predominantly fatty marrow with a little bit of polycellular red marrow. Now, in that condition, which is quite frequent, it's neither normal or abnormal. It occurs in women between the age of 35 to 60, and there is a significant amount of red marrow with a decrease in signal intensity in the distal metaphysis, not in the epiphysis. And this probably occurs in response to mild chronic anemia. Remember the normal value of hemoglobin in women and in men. It's different. Women do have a lower hemoglobin level, probably due to menstruation. Therefore, their red marrow is more active, and it tends to expand in the body to respond to the chronic blood loss. Now, as a rule, and we will see that in metabolic disorders, it is bilateral and symmetrical. You should have the same appearance. If you do follow-up, you wouldn't see any change at all. And as a rule, the signal intensity is that of normal red marrow. Therefore, it's intermediate on T1 and it's intermediate on T2. So far, so good. It's not so difficult. Now we move to an overview on metabolic disorders. You can see that all these conditions in all the different constituents of the MSK system. The muscle, the tendon, the cartilage, the synovium. If you focus on the tendon, you've got to mention hyperuricemia, calcification, fluorosis, quinolones and tears, and so on. We will just forget all these conditions to focus on the bone diseases and on the marrow diseases. You know the names of most of these conditions. To summarize, to provide an overview on metabolic disease, and in that point they differ from many, many other categories of disease. These are systemic disorders. The entire body or the entire MSK system can be involved. There are important geographical differences. Some hemolytic anemias are extremely frequent in Africa, not in the northern part of Europe. As a very important point, most of these conditions are treatable. And if you make early diagnosis, you can prevent the complication. Unfortunately, all of these diseases, except marrow conditions, they have a long clinically silent phases. So actually, I might have osteoporosis or osteomalacia, but I'm not feeling any pain. So the diseases are silent, and many times the diagnosis will be made at the time of complication, and this is our role in most of the diseases. Having said that, although these diseases involve the entire skeleton or the entire marrow, the involvement might be uneven, or it may predominate in the trabeculi, or it may predominate in the cortex. Well, if osteopenia predominates in the cortex, you will have a fracture of the femur. If osteopenia predominates in the trabecular bone, then you've got a spine fracture. So although it's diffuse, the manifestations might be focal. Now, a major issue, if you want to understand the next part of the lecture, is to clearly understand what I'm doing when I look at the bone and what I'm doing when I look at the marrow. This is a section from a fresh cadaver where you see yellow areas and red areas. If you take a radiograph of that piece of femur, you just see the cortical bone and the trabeculi, but you have no single idea of the medullary content of that piece of bone. Therefore, you need a coronal T1 weighted image to have the same picture, but you will notice that this correlates to that photograph. This is the same in this spine, where there are multiple vertebral fracture, healed, old fracture, possibly osteopenia. You will see that the corresponding MR image is totally normal, except that we see high signal intensity area that corresponds to fat deposits within the red marrow. So the picture that we see is totally different. If you look at a radiograph or a CT, you will have an idea of the mineralized component of the bone, whereas if you look at a sagittal or a T1 weighted image, you will see the bone marrow. Now let's move on to the diseases, and these are two different patients. They died. I've got the specimen. Their spine has the same color. it's red marrow. One has a marrow disease, the other one has a bone disease. Let's do an X-ray. These are the corresponding radiographs. Look at this vertebral body. The trabeculi are numerous, and it seems to be normal. However, on the other patients, you've got multiple fracture, obviously, and then the trabecula are barely visible. This is osteoporosis, and we will see it on the radiograph, although the anatomic section really looks the same. What about the marrow disease? Well, for the marrow disease, we need the MR and we need a T1 weighted image. And these are the corresponding T1 weighted image. Look at that bone marrow. It has a normal signal intensity. It's higher than the adjacent disc. Look at that patient. Well, the signal of the bone marrow is equivalent or lower or higher, depending on where you look at, with respect to the adjacent disc. And if you look at the corresponding microscopic section, you see a lot of fat cells in that elderly patient. And here, there is not enough adipocyte, and there is marrow infiltration by an abnormal process. So this is marrow disease that we will see on MR, and this is a bone disease that we'll try to see on CT or X-ray. Now, knowing that and having that in mind, we move to the metabolic bone disorders. And we will focus a little bit more on osteopenia and osteoporosis because these two diseases are largely the most prevalent conditions. If you look at this hand radiograph, this is a normal metacarpal bone, and to help you to look at the place to look, I put arrows on both sides of the cortex, and this is the thickness of the cortex. Look at that patient. Look how thin is the cortex. The distance between the outer and inner aspect of the cortex, it's much thinner. This is osteopenia, and it's a quantitative bone disorder. Osteoporosis has an official definition. It is a disease. It's not normal. It is a disease in which two things do occur. There is a reduced amount of bone per volume, which is called low bone mass. And in addition to this quantitative disorder, there is a minor qualitative change as well. There is a deterioration of the trabeculi, of some of the trabeculi, mainly the horizontal. And these two features lead to what? Actually nothing except that there is an increased risk for fracture related to enhanced bone fragility. And that's really where the disease is. The diagnosis of osteoporosis must be based on technique which measure the bone density. This is no more radiograph CT. It is dual energy X-ray absorptiometry. There are rules, there are values which are adapted in each country. You have different definition based on these features, and when you mix these data and risk factor, there are some techniques which enable you to predict the risk for fracture. Then you might decide to treat the patient without fracture, but with a high risk of fracture to prevent these fractures. That's the deal. Note, I will not give you the list of conditions in which you can have osteoporosis. Basically, there are two forms. One is primary osteoporosis, which is the one that we see every day, like postmenopausal osteoporosis or senile osteoporosis. These two conditions are different. In postmenopausal osteoporosis, obviously it's more in women than in men. It starts earlier than the senile form, and the first fracture is usually the wrist or the spine. Whereas if you've got senile osteoporosis, you've got hip fracture because the cortical bone is more involved than the trabecular bone. These are pictures that you will see every day in your practice. And this is typically what you will see. This is the hand that we know, a very thin cortex, decreased bone mass, and here it's extremely difficult. You cannot decide whether or not there is osteoporosis, and I cannot either. Except that all of you, including me, we can see that there are fractures. So probably the patient has osteoporosis. Now, please, this is extremely important. Do not rely on the radiolucency on your radiograph. These can be influenced by technical parameters that you can see here. Therefore, it's not because it's white that you have got a lot of bone or black that you have less bone than the other one. There have been tools that we have been using, such as radiogrammetry, in which you can measure the thickness of the two cortices. It's nice. It works. It provides you a good idea. Unfortunately, it does not help you to predict for fracture. Therefore, except in some clinical studies, the referring physician do not ask us anymore about that. But it works. So if you look at a hand radiograph, you can decide whether the bone mass is decreased or not. There are some more sophisticated techniques that have been developed over the years, but they are not in use anymore. The elderly here might remember the Singh index, in which there was progressive disappearance of the trabeculae. Forget it. It doesn't work. That's historical. It belongs to the past. Now, in this patient, there is osteoporosis, decreased bone mass. Look at that one. It's another patient. The thickness of the cortex is equivalent to that. But if you look at the structure, at the quality of the bone, you will see superb tunnels within that cortex. It's no more compact. It is highly permeable. There is bone resorption and no bone formation, and this is called osteomalacia. In opposition to osteoporosis, osteomalacia is a rather qualitative disorder of bone, which is characterized by deficient mineralization. We resorb the bone, but the bone that we rebuild does not take up the calcium and the phosphor, and it does not become mineralized. And in this situation, the bone becomes soft. They can have an abnormal shape due to progressive microscopic fracture, and this is what we call osteomalacia, just like we had chondromalacia, where the cartilage is soft. Well, in children, that condition might be frequent in some areas. You've got additional changes which are important to recognize to make a specific diagnosis, because once again, and it's important to diagnose disease which are treatable. If you treat these patients, then the bone will reappear in a normal appearance. So it's important not to miss treatable disorders. Now, this is rare, and you haven't seen that for a while, and I haven't either. These were the so-called traditional loser zone, which is actually fracture in which there is no callus, so there is predominant bone resorption. Well, there is callus formation, but it's not mineralized. Therefore, you see these fractures. I wouldn't dare to ask you how many of you have seen these recently. I would be surprised there would be a lot of people, because we miss them. And the reason why we miss the loser zone is this. On MR images, we barely see the cortical bone. And this is a loser zone from the patient that I couldn't show the X-ray here, but this is a loser zone, and it's not recognizable as a fracture. By the way, you will notice that the rest of the femur or the acetabulum is normal, although the patient has osteomalacia. This patient was referred to us from a cancer hospital. A lot of metastasis. They couldn't find the primary tumor. Well, if you look at the bone scan, which is nice for this condition, you will see multiple hot spots. And if you look at the X-ray, nothing to be seen. And on the MR, look how it is similar to a metastasis. And we can understand the colleagues. Well, these are some unusual fracture with a little of deformity, but a lot of non-mineralized callus that are seen in these patients. And actually, The diagnostic, the MR feature that you will see in osteomalacia is this. You've got multiple fracture in many, many areas. But some of these look like chronic fractures. Other might be more recent with more edema. These patients do have multiple fractures that accumulate over the time and last a long time because they do not heal correctly. One image, one diagnosis. Hyperparathyroidism, severe bone resorption everywhere in the skeleton, but you can see it nicely in the hand. It can be primary or secondary hyperparathyroidism. You have books and papers to read on that. You have to look at that cautiously, and these are two different patients, a normal phalanx and an abnormal phalanx. You can see the tiny interruption of the cortex. There is interruption on the endosteal aspect as well, but you don't see it clearly well. You see it nicely on the subparietal area. Once again, if you treat the condition, it returns back to normal. So please recognize this disease, and you will see these conditions quite frequently in patients with chronic renal osteodystrophy. You've got a mixture of osteoporosis, hyperparathyroidism, aluminum intoxication. You've got some sort of osteomalacia with bone deformity, unusual arthropathies in the hand or in the spine, and so on, and soft tissue calcification. It's a whole spectrum that you will see in patients with chronic renal insufficiency. So the key messages, if we focus on metabolic disorders, is this. Medical imaging can neither detect nor quantify osteoporosis. Although if it's present, we might say it. The goal that we should achieve is to detect and characterize occasionally the complications, which are fractures and occasionally deficient healing process. And please note that the fracture remain occasionally not identified by the patient. They had pain, then it goes away. And the key point that there is a fracture has not been mentioned. Please, let's focus a little bit on the fracture, and we will focus on insufficiency fracture, and with the stress which is applied on the bone as normal, but the bone strength is reduced, and this is what we call insufficiency fracture. The most frequent pattern is this one in the spine. A lot of trabecular bone, a lot of vertebral compression fracture. What you will see on X-ray and on CT is abnormal shape. The shape of the vertebral body is nicely seen on the CT and on the X-ray. If you look at the corresponding MR, the striking abnormality is the marrow change, and you have to pay attention to the shape of the vertebral body to recognize the abnormality. It's not so easy. And this is abnormal marrow, decreased signal intensity, lower than that of the adjacent disc. This is T1, and if you look at T2, you will see the most important feature, which is the fracture. We have seen the deformity. You will have to look to search actively, not on axial images, obviously. You look for the impaction fracture where it is visible, occasionally on T2, occasionally on T1, occasionally on enhanced T1 weighted images. You look for a line which indicates the fracture. As a rule, all of these benign fractures must heal within 3 months. Therefore, if you do follow-up, in this case at 2.5 months, there is a significant regression of the abnormality on the T1 on purpose. I deleted all fat-sad images from this talk because what I tell you is applicable on T1 and on T2. It's another lecture to focus on the fat-sad, but fat-sad is dangerous if you want to characterize a lesion or detect healing as in this patient. A section from a cadaver, sagittal T1, fat set, edema. Look at the line. Well, the line is better seen on the T1 than on the fat set. And if you look at the X-ray, you will see that area of sclerosis, which is always or quite frequently located underneath the vertebral plateau. And this is the cartilage, the subchondral bone plate, and this is the fracture with callus formation and a little bit of marrow infiltration. This is what we see every day on T1, on T2, and if you add GAD and you use a Spineco T1 weighted image, you have a return to normal, which is an excellent sign for a benign fracture. What is that? It's a coronal T1. You've got a huge lesion. Look at the fat set, the T2 weighted image. You've got a line. I cannot make any diagnosis on that image. We should all make the diagnosis of an insufficiency fracture. This is the fracture line. I spend a bit time on that because it's important to recognize a specimen, low on T1. This is the line, nothing on the X-ray, a little bit on this section. And then if you look at the histology, you will see fracture, and I show you one fracture. This is a trabeculi, the fracture line, and then you've got callus formation. It's, for the women, it's a pearls, a pearls that is hanging on the trabeculi. A fracture, early CT, nothing to be seen. 3 months later, the patient is doing well, a lot of periosteal reaction. Look at these nodules hanging on the weight-bearing trabeculi. These are the fracture, and the fracture line aligns on a line which is suggestive of an impaction fracture. Now, these are the typical findings, and I want to mention just a few words on uncommon fracture because it's important to recognize them. This is last month. If you pay attention to these diseases, you will see them. He's got right hip pain because he lifted a heavy chair. The X-ray are roughly normal, and if you look at the coronal T1 weighted, there is marrow infiltration, which has high signal intensity on T2 or fat sat, and you will see the lines. So this patient, although he did a minor effort, he's got a fracture of the epiphysis. 20 years ago, a spontaneous fracture of an epiphysis meant it was osteonecrosis. This is no more the case. You have insufficiency fracture, and we did the blood test, very low level of vitamin D and a very low level, a very low T-score. So this is really a very frequent presentation of metabolic diseases every day. The insufficiency fracture of the epiphysis are quite frequent. They largely predominate in the lower limb, always or almost always the convex articular surfaces. The X-rays are usually non-contributive, and MR imaging helps to make the diagnosis, although there is a large differential diagnosis for this condition. Another fracture, which is not so rare if you are aware of, is the longitudinal insufficiency fracture. Marked edema on MR and on CT, this is the fracture line. It's a longitudinal fracture, and this is a typical image of a longitudinal cortical fracture. You've got cortical rupture and callus formation on both sides, the subperiosteal side and the endosteal side. Look at the corresponding MR. You must be very good to make the diagnosis on T1 or on T2 if you are not aware of the condition. So never hesitate if you are facing a bone condition to add a CT to look for the diagnosis. These fractures are important to recognize, and unfortunately, they are becoming more and more frequent. 77-year-old man, diabetes mellitus, chronic renal insufficiency, dialysis, got pain on the left side, nothing on the X-ray. Corresponding MR, low on T1, high on T2. You might give an extremely large differential diagnosis. It could be a metastasis, it could be myeloma, it could be an infection, whatever you like. Please think of this fracture. Where is it? I don't know. Some of you might help me to show that area. Well, if you look at the axial image, T1 and STIR, you will see edema in the marrow, edema in the soft tissue, focus on the cortex. Here it is. And we had to do the CT, comparative CT. This is the fracture line, and on the reformats, it has a longitudinal orientation. Pay attention to these lesions. They may break, and then you've got a lot of problems because that means surgery and complication. This is misleading. You always, in that area, have a huge marrow change. I don't know why, but it's quite frequent. So MR leads you to a marrow condition. Please look at the CT and you will see the fracture line, which on this image is located in that area. Not recognizable unless you have seen it once. So I am sure you will see it if within the next week. It's quite frequent in our elderly population. Now let's focus on the marrow conditions, if you like. There is a major situation which is called red marrow hyperplasia, which occur in response of many, many conditions like vitamin B12 insufficiency, smokers, some hemolytic anemias, and then there are rare conditions. We don't see them, although they are present. And this is a patient, June 13, has got an acute spondylodiscitis on T1. It's slow on T1, and it's bright on fat SAT. Disc has a high signal intensity and only minor adjacent soft tissue change. But this is discitis. The patient was treated, and 3 months later, this is the same sagittal T1 and sagittal fat SAT image. It's doing well on the joints aspect of the condition, and it's healed spondylodiscitis. Okay, what did I miss? Well, if you go back to the initial image, if you look at the marrow signal intensity away from the condition, you have to recognize that the signal intensity is very low. It is not acceptable. It is lower than the adjacent disc. It does not mean that there is cancer. No, it's just too low. There is not enough fat. And if you look at the blood test, it's got 10.9 hemoglobin level. And this is 4 months later. As you can see, the signal intensity becomes higher than that of the adjacent disc, and the hemoglobin is normal. So the signal intensity of the bone marrow in your everyday practice is largely influenced by the blood content, and if you have not enough hemoglobin, the red marrow will be stimulated. If you have a cyanotic cardiac problem, you will have a hypercellular marrow to try to support the body to give enough oxygen everywhere. Another patient has got abscess, like you have seen yesterday, abscess in the epidural aspect. Look at the T1, T2. This is markedly reduced signal intensity. And red marrow hyperplasia may obviously interfere with focal lesion detection on T1, and it may mimic marrow infiltration by any process. This is not specific, and it's not rare. There is a problem in those of you who perform follow-up of patient under chemotherapy, and this patient has chemotherapy and hematopoietic stimulating factor. These are used to stimulate the different cell lineage to reduce hemorrhage and infection. It has also an impact on the red marrow lineage. And if you see before treatment, this is during treatment, very low signal intensity, but it's transient. If you stop the treatment, then the red marrow becomes normal or even more fatty. This could be related to the chemotherapy. One of the problems is that red marrow hyperplasia can be diffuse in the spine, but it can create nodules, just like the fracture that I have seen you. Look at these nodules. If you tell me this patient has multiple myeloma, I will say, well, there is a lesion here. There is no multiple myeloma. This is before treatment. This is after treatment. Look at the marrow here. It becomes more cellular. Here it's a diffuse pattern. Well, in the appendicular skeleton, it can be focal. And that may lead you into trouble. The only solution is to ask the clinician whether or not the patient has such a treatment. That one has angiomas. Before treatment, he had a cancer as well. As you see, the difference with the angioma becomes more important because the rest of the marrow has a very high signal intensity. If you see that, ask the clinician. If they stop the treatment because the session is finished, then it returns rapidly to normal. I'd like to just emphasize one point once again. Once you have seen it, you will recognize it every day in patients with cancer or any sort of cachexia. And this poor woman had metastasis, and she was on treatment, and she progressively, May, July, December, developed cancer-related cachexia during the end of her life. And if you see the fat, the subcutaneous fat, it's gone away. If you look at the intermuscular fat, it's gone away. And if you look at the marrow fat, well, this is not strictly normal. And as you can see, the metastasis is increasing progressively. Now, this is a condition which is called serous atrophy of the bone marrow, which involves the yellow marrow, the fatty marrow. In patients with anorexia nervosa or any sort of cachexia like cancer or hyperthyroidism, you will see this picture. This is a standard T1 weighted image in a patient without fat. And this is a patient with fat, but it's a fat-saturated T1 weighted image. And you can see that the gradient of the signal intensity is rather similar. So this is serous atrophy in some patient. It predominates in the axial skeleton. It gives a bizarre image in the spine. Now, this is transient. And that patient had 10 kilograms more a few months later. We did the sagittal T1 to compare. This is before and after the 10 kilograms. The fat comes back. The signal intensity of the muscles returns to normal. This is serous atrophy of the yellow marrow. It transformed to some mucopolysaccharides. Instead of accumulating lipids within the cells, you've got fluid out of the cells. Now, if we go back to the patient with moderate anemia, like this woman, low on T1, low on T2, she has moderate anemia. That patient has some form of thalassemia. It's a young guy. He's got a long-lasting anemia. Then there is expansion within the epiphysis. You should not see that in normal patient. If you get abnormal marrow in the epiphysis, this is no more a normal variant. There is a problem, and that patient had thalassemia. In addition to the abnormal extension within the epiphysis, there is marked decrease in signal intensity on T2 that becomes equivalent to that of the muscles, and this is called hemosiderosis. It's related to the accumulation of iron within the bone marrow, mainly in the macrophage. It's physiological at birth. I showed you the very low signal intensity. All the babies have a lot of iron within the red marrow. Now, if you do a lot of blood transfusion, you can have this unusual appearance of a rather normal, although a little bit heterogeneous marrow on T1 and very low, markedly low on T2. This is no more intermediate signal intensity. This is very low signal intensity on T2, which is related, in this case, to hemosiderosis. You have to be aware of that images because you will see patients with this disease. She came to us for septic arthritis. So you should consider this abnormal signal intensity within the marrow, the liver, and so on as an expected finding and not at an abnormal condition. It is related to her condition. Other example, in patients with sickle cell anemia, you've got expansion of the red marrow within the appendicular skeleton. This is not normal, but you don't see anything on T1. You will see high signal intensity on T1, which presumably represent large marrow infarcts. You've got to look at the soft tissue. If the soft tissue are significantly involved, you might be dealing with an infection. You will not, in these patients, be able to detect the lesions on T1 and on T2. You might need the injection of contrast material. That patient had a sickle cell, back pain, suspicion of infection or infarction, very low on T1, very low on fat sat, very low on T2, nothing to be seen. And if you inject contrast material, you will see heterogeneous enhancement that probably represents ongoing infarct within the red marrow. So to conclude with the marrow conditions, marrow changes are frequently unrecognized by the radiologist by chance. This underreporting has no impact on the clinical management of these patients because the clinicians have all the information from the blood test or other tests. So they are not waiting from us information. But we have to be aware of these changes because the bone marrow becomes abnormal and the conspicuity of the lesion is reduced, at least on T1 weighted images. Marrow hyplasia is the reverse situation in which the signal intensity is too high for the age of the patient. If this patient is 85, it might be normal, but it was not the case. It was around the 30s. So this is marrow hyplasia, which can be of various origin. And I'd like to end this lecture with a very, very frequent situation because steroids have a variable impact both on the bone marrow and on the mineralized component, although you know that steroids also have effects on the tendons with tendon ruptures, muscles with fat atrophy, and so on. So this is the typical body distribution of fat with fat reduction in the peripheral skeleton, fat accumulation in the central body with small infarcts in the epiphysis. Now, they have large numbers of effects both on the bone cells and on the marrow cells. You should be able to recognize steroid intoxication on that image. You've got multiple fracture and multiple hypertrophic callus adjacent to these fracture. If you are very good, you might guess that there is some form of atrophic osteoporosis, which is also highly suggestive of steroid intoxication. On CT, you will see exactly the same. Look at the trabeculi that gone away. You will see the multiple fracture with callus formation and difficulties in healing with intraosseous vacuum phenomenon, some sort of pseudoarthrosis, which are related to the difficulties in healing of these patients due to steroids. On MR, you've got a too white marrow because there is lipomatosis everywhere in the soft tissue, in the muscles, in the epidural space, or in the bone marrow. And you will see the fracture. The fracture in these patients usually have a little amount of fluid around them, probably because there is not much space around because of the fat lipomatosis. And this is the same patient seen at multiple occasions on MR. You can see the development of the fracture and the persistence of the fracture line of more than 6 months, which is not acceptable in a normal patient. You have that bizarre appearance of modic type 2 changes on one side of the joint. The disc is normal. There is no modic change, no fatty accumulation on the other side. It's a unilateral problem which is related to the fracture and accumulation of fat within the callus. So to summarize this lecture, I just want to remind you that metabolic disorders are extremely frequent in your everyday practice, and they are treatable diseases. Therefore, we must recognize there are a quite large number of targets. However, the conditions remain silent for a year, and we play no role for the detection or the quantification of the disorders, but we play a crucial role for the detection of fracture, characterization of this fracture, including the unusual forms of fracture in all these patients. In metabolic marrow disorders, it's frequently underreported, but it's not a problem. Forget it. They know everything. What you have to know is that if you have an abnormal marrow metabolic condition, the bone marrow may look normal, and we may not be as good as before. for the detection of complications, which are more variable than in the metabolic condition. Thank you.